it's a pleasure to introduce Dr. Michael Fralick. He's a 2024 Canada Gairdner Early Career Investigator and a clinician scientist at Sinai Health and at the Lunenfeld-Tanenbaum Research Institute. He also serves as an associate professor at the Faculty of Medicine at the University of Toronto. His research journey, I think, is a fascinating one, as his PhD was completed at the University of Toronto, exploring the intersection of supervised machine learning and pharmacoepidemiology. However, during the COVID-19 pandemic, he shifted his focus to pragmatic clinical trials to rapidly identify effective treatments for COVID-19. We are very fortunate to have Dr. Fralick with us today to present what I think is one of the more catchy presentation titles I've ever seen, so please join me in welcoming Dr. Michael Fralick to the stage.
Yeah, nice to meet you. All right, everyone can hear me okay? Awesome. So I'm a general internist, and every holiday I have to re-explain to my aunts and uncles what that actually means. But during the COVID-19 pandemic, it was simple. I looked after patients when they were sick and hospitalized with COVID-19. Over the next 10 minutes or so, we're going to talk about WTF, why the floor might hold the key to preventing outbreaks and monitoring respiratory virus activity. Let's see if this works. Perfect. So this is my condo in March of 2020, and during that time I was activated from backup, and I was going to be one of the physicians looking after patients as they were being hospitalized across the street at Mount Sinai Hospital. It's funny to look at this in retrospect, but my biggest fear was not getting the virus, but spreading the virus to my wife, to my loved ones, to my family. So we duct taped off the condo, as you see there. So for the next 2 years, most of my time was spent in hospital looking after patients with COVID-19. But very early on in the pandemic, we started to see headlines, catchy headlines that hydroxychloroquine might be life-saving. Blood thinners might be life-saving for the sickest of people. These headlines were based on expert opinion and non-randomized studies. That is the last thing that we need. That is the last thing that we need. So we decided at Mount Sinai Hospital, I helped to lead the infrastructure for COVID-19 clinical trials. We ran 7 days a week for the first year and a half of the pandemic, and every single patient who was hospitalized on the general medical ward was considered for one of many randomized trials. So these included trials of prone positioning, of convalescent plasma, of identifying that hydroxychloroquine definitely does not work, but remdesivir is life-saving, and that blood thinners actually do help, but in a certain subset of patients. So these trials went on to inform globally how we care for patients with COVID-19, even up until today. At the same time, what we saw during the pandemic early on was the morbidity and the mortality that outbreaks caused in congregate settings, long-term care homes, hospitals. I can think of the patients that I cared for at multiple hospitals. They did not come into hospital with COVID-19, but they acquired it via an outbreak and died in hospital from it. That is incredibly heartbreaking, and I still think about those patients. And early on, there were initiatives to think about, well, how could we maybe track the virus? And I think what we're all very familiar with is wastewater surveillance. The idea is simple. When individuals are sick and unwell with the virus, they shed the virus in the feces, and that can be recovered in wastewater. But there was a group in Ottawa that thought about this a little bit differently. You know, we know now that the virus spreads via aerosols and droplets, but they got to fall down at some point in time. So could we swab the floor? Could we swab the floor to determine the disease activity within a hospital, long-term care home, you name it? These swabs would then be brought to the lab. They could be processed using PCR to determine whether or not the virus is present. So our tagline was simple, why swab feces when you can swab the floor, okay? And that's exactly what we did. So over the next year and a half, we ran a multi-center study in long-term care homes across the province of Ontario, where we would swab twice a week. Those swabs would be sent to the lab and processed for SARS-CoV-2. This figure here represents each individual long-term care home. So 10 long-term care homes in total. On the y-axis is the percentage of swabs from the floor that detected the virus. In red was when an outbreak was identified. So what you can see here is that there's often a lead time where we know there's an outbreak that's occurring because of what's on the floor, but the home hasn't recognized it yet. So this study was subsequently published and demonstrated that we can predict and potentially prevent COVID-19 outbreaks in long-term care homes. We also did work at the University of Ottawa, where we swabbed at residence buildings, gyms, libraries. And on the top panel here were the number of COVID-19 cases reported among students and staff, and the next bar is a swab positivity. So again, what percentage of swabs from those buildings were we finding the virus? We also had access to wastewater data from the region, and you can see that the wastewater data is not as strongly correlated, and that makes sense. Wastewater lacks the spatial resolution, whereas with this technique, we can tell you what area of the room has it, what floor has it, you name it. Now there's more to life than COVID. There's more to medicine than coronavirus. And around this time of year is when I start looking after patients who are hospitalized with other respiratory viruses, influenza A and B, as well as RSV. So now we've developed a multiplex so that with one single swab, we can detect all of these viruses, and we have another lane or panel for whatever that next virus might be. So in March of 2024, some of you might remember and recall human cases of H5N1. We heard a little bit about this this morning. Predominantly, the human cases we've seen so far are quite mild. This individual is a farm worker and has conjunctivitis, but the symptoms are relatively mild, so that when you see a patient or when you see a physician, the physician will say, "You're going to be okay, go home," okay? You cannot rely on human-based testing to give you a sense of how active is the disease. So we recently got support from a rapid call from CIHR to do some prospective surveillance. So this has already begun at hospitals across the Greater Toronto Area, Sault Ste. Marie, where I also work, and in Ottawa, as well as veterinary clinics. My wife is a veterinarian, so finally we get to work together. But we know that dogs, cats can carry the virus, and of course birds. There are wildlife centers that we're going to be swabbing at, and there's something called exotic vets. It's not what you think, but these are vets that specialize in looking after birds, lizards, reptiles, and we'll be swabbing there too, and hopefully farms as well. So I hope this will be an example of maybe can we get One Health to work. Now there's more to viruses, there's more to diseases than viruses. What about bacteria? This is some very early work that we've just started. So I work across the street at Mount Sinai Hospital. It has one of the few level 3 NICUs in the country. So they look after the most premature babies. And one of the #1 causes of death in these babies are bloodstream infections. And they get them from the environment. So this was a Guinness World Record. These are twins born at age 22 weeks. That's never happened before. This was now 2 years ago. And right now, if a neonate has a fever, a doctor, a nurse will then order a blood sample. They will send that blood sample to the lab. This takes time, and you'll wait for the bacteria to speciate, but also identify what is that bacteria susceptible to. What we wonder is whether or not we can swab the environment, the floors, the incubator, to use a non-medical word, the tubes that are connected, and whether or not can we identify the bacteria, but also can we identify markers of antimicrobial resistance genes. And this is using Illumina, NextSeq, as we heard so much about yesterday. These are now the twins at age 2. And for me, it's like, if we could do anything to help a baby in that NICU, like, I'm sold. So this is the most important slide of the talk today. This is the much larger team. So our team is CUBE, COVID in the Urban Built Environment. It's a team of undergraduate students, medical students, graduate students, physicians like myself, basic scientists as well, and hands down one of the most exciting teams that I've been a part of because it truly crosses disciplines. I'm learning about things like genomics that I still don't totally understand, but I have team members that do. And we were able to get support from these granting agencies. Every grant we got here, we were rejected 3 times over, so this is not all success, but I'm very appreciative for the granting agencies. And I think as well it's important, I know there's less high school students today, but when I think about my job and my work, I try to bestow and tell my mentees that your job is just your job, okay? There's more to life than that. And for me, the best job I have is being a dad and a husband. So thanks so much for your time, and it's been a pleasure to be here today.